Madam, please start the class, madam. Madam, can you hear me? Please start the class, madam. We are live now.
Okay. Good evening, students. Today we are going to have a class on surgical wound infections. Last class we had wound healing and the mechanisms that help and even prevent wound healing and various phases of wound healing, and we have done some MCQs. Today we are going to see what are the factors that cause wound infections. How do we classify these wound infections? How to manage these? What are the dangers of these wound infections? How they are detrimental, right? So now see, these wound infections have been recognized very, very early, as much as several thousand years back. People were not understanding what is the cause of this pus that is pouring out. Some thought it is good, some thought it is bad. Hippocrates said that we should use antiseptics like vinegar and acetic acid and wine and vinegar to be put in the wound to decrease the infections. Then Celsius told the signs of inflammation. If the wound gets infected, there will be Kala, Dola, rubor. This indicate that there is infection. But actually, they are not knowing that the cause of wound infection is a microbe. Then came the Koch postulates. Koch is the one who said that in order for the infection to be associated with a particular organism, certain postulates have to be satisfied to relate the infection to a particular organism. That is, first one is the particular organism. Actually, this organism to be the cause of infection is found by Louis Pasteur. Louis Pasteur is the one, and then Lister, Joseph Lister is the one who has devised his antiseptic carbolic acid spray, antiseptic spray to decrease these organisms. Koch's postulates consist of that these organisms should be in considerable numbers to be a cause of the septic focus in the wound, and then these organisms must be able to be cultured in a pure form if that is to be the cause of the wound infection. Then they should be able to produce similar lesions when injected to another host. These are the postulates. Only if these postulates are satisfied, we can relate that the particular organism is the cause of infection. So when not much of inroads have been laid to the causes of the infection, Koch was the one who threw some guidelines to know that this is the organism causing the infection. So we have already discussed Louis Pasteur and all. Now, what is the main challenge that we have in surgical practice? In surgical practice, first is the beta-lactamases. That is, many bacteria develop resistance through acquisition of enzymes called lactamases, which break up the beta-lactam ring in the antibiotics. The antibiotics have a beta-lactam ring. If this beta-lactam ring is broken, the antibiotic will not be able to kill the bacteria anymore. It loses the capacity of the bactericidal action. So many bacteria are developing these beta-lactamases, especially the Staphylococcus aureus. And then the emergence of methicillin-resistant Staphylococcus aureus, the MRSA, and now we have a glycopeptide-resistant enterococci. So these are the challenges now in the surgical practice. So we should be able to know and understand the causes of surgical wound infections and prevent them from occurring rather than treating with loads and types of antibiotics, because there are many of the bacteria are acquiring resistance to many of the antibiotics that are available. So now, but still we have achieved control of infection in surgery because of aseptic operating theater techniques in place of toxic antiseptic technique. That is, previously they used to spray the carbolic acid directly into the wound to decrease the bacterial count. But now we are not doing it anymore. We are doing the aseptic operation theater techniques. That is, we are fumigation of the operation theaters, and then autoclaving of the instruments, and then filtered air filters in the theater, and decreasing the movement of the people. So many things, the aseptic techniques we are following, which is controlling the infection in surgical wounds rather than aiming at treatment of wound infections after their occurrence. Next, we also have prophylactic antibiotics. When we think that there can be an infection, we are giving prophylactic antibiotics prior to surgery itself, and we are also giving post-operatively as a therapeutic dose the antibiotics when we think that there is a chance of wound infection because of spillage or contamination. Next, we are also following various methods of wound closure. We have a, instead of primarily closing all the surgical wounds, we know that we can do a delayed primary closure or leave the wound open if we find that there is a chance of contamination in the wound. So these methods of dealing the wounds of the surgery and also the place of surgery have advanced in controlling the cause of surgical wound infection. But now we have certain barriers for wound infection in our body. What are these barriers for wound infection? We have mechanical barriers, chemical barriers, humoral barriers, and cellular barriers. The mechanical barriers are the skin with all its layers and the mucous membrane. If these two are intact, bacteria cannot penetrate this barrier. But if there is a breach in the skin and mucous membrane, they can penetrate. But encapsulated organisms like pneumococci, meningococci, hemophilus, influenza can penetrate even an intact skin. So we have other methods of barriers like chemical methods. We have a very low gastric pH. The pH in the stomach is as low as 2. So if by chance any organisms are entering through the diet or through the oral route, these bacteria are immediately killed in the gastric acid in the stomach. Next, we also have humoral barrier, that is presence of antibodies, complements, and opsonins in the blood due to previous exposure to these antigens. They prevent primarily any establishment of infection. Next, you all know we have the defense mechanisms in the blood, that is the phagocytic cells, the macrophages, the polymorphonuclear cells, and the lymphocytes. All these, we have a cellular mechanism which if the body senses a foreign protein entering it in the form of bacteria, virus, fungus, or any chemical, there is triggering of this inflammatory reaction which immediately phagocytizes the bacteria if it is in the less number. So the barriers of wound infection are mechanical, chemical, humoral, and cellular. But now we have, in spite of having all these protective mechanisms and following the aseptic theater mechanism, still there is a chance of wound infection because the person or the patient himself might be suffering from infections or diseases prior to the surgery or the wound that has occurred. So he may be malnourished. Malnourishment can be undernourishment or overnourishment. Even obesity is considered as a malnourishment. And presence of metabolic diseases like diabetes, uremia, jaundice, all these are a cause of decreased host resistance. And this immunodeficiency states like disseminated cancers and acquired immunodeficiency syndromes, the HIV infections, and also iatrogenic, that is by the treatment itself. Suppose the patient is undergoing some treatment, the treatment itself may decrease his immune status, like a chemotherapy for a cancer, or a steroid treatment for an autoimmune disease, or a radiotherapy locally for a cancer. So all these decrease the host resistance to infection in spite of many precautions that we take. So not only the malnutrition, metabolic diseases, and immunosuppressions, we also have other causes like colonization and translocation of bacteria in the gastrointestinal tract, and then poor perfusion of the wound because of the the systemic shock. The patient may be hypovolemic because of loss of fluid or loss of blood, which produces a state of shock, in which case the surgical wound will not have a good perfusion, so it cannot start the initiation of wound healing process. We all know inflammatory phase is the first stage where the platelets and the macrophages have to come to the surgical wound. If there is poor perfusion, these cannot reach, and the inflammatory phase of the wound healing cannot start. Presence of a foreign body material is again against wound healing, because this will attract bacteria. This acts as a nidus or a focus for a bacterial proliferation, and so an infection will be established in the wound. Poor surgical technique, that is, I have already told in the last class, if the tissues are handled roughly, or if they are not closed properly, leaving dead space, so and then hematoma, seroma formation, in these cases, the bacteria that have colonized from the surface, spilled from a surface, can establish infection. So now, what is this translocation and colonization of bacteria from the gut? So, see, suppose a person is kept in nil by mouth for several days post-operatively. What is happening to him? So, this produces ischemia of the gut. And also in a state of severe shocks, there is ischemia of the gut. So, the housekeeping of the gut mucosa is not occurring. This will produce weakness or breach in the mucous membrane. Breach in the mucous membrane. So I have told you that if there is a breach in the mucous membrane, the bacteria will start entering the cells. So once they start entering the cells, they colonize there and they start multiplying within the cell, and they release the endotoxins. Now these endotoxins reach the circulation. So they colonize in the epithelium, they colonize in the nodes, and then they reach these endotoxins are now released into the circulation. You know, the endotoxins are the transforming nuclear and the tumor necrosis factor, interleukins, all these are released into circulation. We have seen that in the wound healing, these produce vasodilatation. So when there is vasodilatation, these reach vasodilatation, they produce vasodilatation. So now the permeability of the vessels is increased. This causes a release of fluid from the vascular endothelium outside. So to the interstitial tissue, the fluid shifts. So this produces third space loss of fluid. That is, into the cavities, the fluid is lost from the circulation. So this is called SIRS, systemic inflammatory response syndrome. And then this leads to MODS and MSOF. We'll see what it is. So even there may not be any reason, simple ischemia or hypovolemia or nil by mouth. If you keep a patient nil by mouth, not allowing anything post-operatively for a long time, will produce septic shock. So immediately post-operatively, the patient should be allowed as early as possible his meal. So something should be given per orally, which will decrease the chances of bacteremia and septicemia. Now, what are the factors that determine whether a wound will become infected? You all should know that these should be avoided already. The host response, if the host is good enough in health status, he will generate a good inflammatory response and the wound is going to heal. You also should know what are the virulent factors that occur. What are the virulence and what is the size of the inoculum that has occurred of the infective agent. If there is cross contamination, spillage, suppose you are doing a gastrointestinal tract surgery and suddenly there is spillage of the juices, the bile or the intestinal contents into the surgical wound, you know that there is going to be a surgical wound infection, or sometimes even local intraperitoneal abscess formation, sepsis also can occur. Then you also should know what is the health of the tissues that you are operating, and whether there is any cause of um, hypotension during surgery, or are you going to keep a prosthesis in the wound, just like a mesh in a hernia surgery, or a prosthetic nail, a implant into a bone in a case of a orthopedic surgery. So these are all necessary to know, to understand that if there is going, if the tissues are not vascular, or there is a dead tissue, or we are going to keep a foreign tissue, there's a chance of would become infected. So now how do we prevent the infection? So we should give antibiotics during the decisive period. So what is this decisive period? So this decisive period is the acute inflammatory humoral and cellular defenses take up to 4 hours to be mobilized by the body. So this is called the decisive period. So within this 4 hours, if we can prevent infection, we are going to we are going to decrease the chance of wound infection, because if the bacteria invade during this within the 4-hour period, and already if an antibiotic is circulating, there is a less chance of this bacteria producing, colonizing and dividing. So we should give a prophylactic antibiotic within this decisive period, because the body needs to generate inflammatory humoral and cellular defenses against any bacteria that invade by up to 4 hours time. So now we know what are the factors that cause wound infection. To understand what is decisive period, now let us just classify the surgical wounds. How do we classify the surgical wounds? Basing on which we classify, basing on the degree of contamination, we classify the surgical wounds. What is necessary to have this classification? We want to classify a surgical wound into one particular class or type, because we can understand what is the percentage of or the rate of such infection. So accordingly, we can plan our treatment, that is the antibiotic that we give, when to give. Is it sufficient if you give only in the decisive period, or you have to give post-operatively also? You also should understand the causes, mechanism of the wound infection, how it has occurred. Is it simple spillage, or is it due to the crush of the tissues, or contamination with road dust or bacteria? So what are the bacteria that are involved? Yeah, are they only gram positive, or both gram positive, gram negative, or even bacteroids are also present? What are the systems that are involved? So and what is the condition of the patient? So all these factors will determine to classify the surgical wound into various types. So we classify them as class 1 or clean wounds. So this class 1 or clean wound is that wound which is uninfected operative wound, in which no inflammation is present as prior to the surgery, and the systems which already harbor some commensal organisms are not entered, or the surgery is not being taking place in those systems, that is respiratory, alimentary, genital or urinary tract. These systems are not entered, and the wound, and it's a clean surgery where there is no infection of the wound prior to this. So clean contaminated is, this describes an operative wound in which the respiratory, the alimentary, this includes hepatobiliary, pancreas, the genital and urinary tract are entered, but they're under controlled conditions and without any spillage of their contents and without any prior infection of these systems. So this is called clean contaminated. We have entered, but as such, these systems are not having any infection. But since they have commensal organisms, we call them as clean contaminated. Though they are not having any infection, we can't call them as clean surgical wounds. So once these systems are entered, the surgery is called clean contaminated surgery, and the wound is called the surgical wound, that is the abdominal wound that you have opened is a clean contaminated surgical wound. Now, so in class 3 is called contaminated surgery. Here, these are open, fresh, accidental wounds, that is road traffic accidents. Then when there is major break in sterile technique, that is there is a gross spillage from gastrointestinal tract and already there is lot of cellulitis or acute inflammation of the tissues, or open traumatic wounds that are more than 12 to 24 old. Suppose the person has sustained a road traffic accident. He has come, the wound looks clean, but already 12 to 24 hours have elapsed. So we call them as clean contaminated wounds. And then the surgery where there is spillage from gastrointestinal tract, that is a hemorrhoidectomy, is considered as a contaminated surgical wound because there can be a fecal matter. How much ever you clean, the fecal bacteria will be definitely at the site of infection. So now the dirty wounds are who have dead necrotic tissue, frank pus within the wound already. This can be a road traffic accident wound or emergency surgery for infections like peritonitis or bowel perforation with gross fecal contamination, delayed presentation of traumatic wounds with existing contamination and devitalized tissue. All the military wounds, the road traffic wounds, these are all dirty or infected wounds. So how do we now, in class 1, it is the infection rate is only 1 to 2%. In class 2, it is less than 10%. In class 3, it is 20 to 30%. In class 4, it is more than 40% infection. Rate of infection of the surgical wounds. So once we know that, we can classify the surgical wound into one of them. So a hernia surgery or a hydrocele surgery. These are surface surgeries where there are no infective organism except some commensals on the surface. These are all the surface surgeries where the respiratory and the gastrointestinal genitourinary tracts are not entered are considered as class 1 surgical wounds, and the infection rate should be less than 1%. If it is more than that, we know some break in aseptic technique is there, we have to find out what. So then clean contaminated, I already told, all the systems without infection. Contaminated is where there is infection of these. Suppose an acute calicus cholecystitis with lot of infection and pus. This comes under contaminated surgery. Dirty wounds are an abscess, necrotizing fasciitis, road traffic accidents. So all these come under dirty wounds. Now we have classified the surgical wound. Let us see what are the sources of infection. So basing on the source of infection also, we can assess the rate of infection. So the sources of infection are classified as primary and secondary. Primary sources of infection are community acquired or endogenous source, such as from the bacteria commensals that are there inside. That means there is no infection as such in the body, but if there is any those normal commensals coming out, this is called an endogenous source, such as a perforated peptic ulcer or a community acquired infection. Secondary or exogenous infection, these also are called healthcare associated infections, where they are acquired from outside, from the operating theater, or in the ward, or from contamination during surgery or after surgery due to some complications like an anastomotic leak. So here, because of secondary sources, secondary causes, these are all called secondary or exogenous or health care associated. During the care that is provided to the patient has acquired an infection during the procedures that he has undergone. So this healthcare associated infection is four main groups. It can be due to respiratory, they can have a respiratory infections. When when the patient is put on a ventilator, he may get a pneumonia. Then when he is put on a catheter, urinary catheter for some surgery, urinary tract infections can occur. And then indwelling vascular catheters and other procedures, bacteremia can occur. And surgical site infections also fall under healthcare associated infection, because he might be when he catches the infection because of a break in asepsis in the operation theater. This is also a healthcare associated infection. So now you should also know what a surgical site infection, because surgical site infection is a 4 marks question for you. Then healthcare associated, that is nosocomial infection, is a 4 marks question for you. So the Center for Disease Control and Prevention classified surgical site infections into deep, superficial or deep, and organ space infections, where they affect all the layers of the body and also the spaces within the body cavity. So we have a superficial surgical site infection where only the skin and subcutaneous tissue is involved. Deep infection where other muscle and fascia are involved, and also the organs or spaces in continuity with the surgical wound. And organ or space infections, that is, these are not related directly to the incision that you have placed. Suppose you have done a surgery and there is an abscess, the pelvic abscess that has occurred. So you have done an appendicectomy. The patient has presented with the pelvic abscess. So something like that. Or total abdominal hysterectomy is done. Some infection has occurred. Patient presented with the pelvic abscess. So here, so they're not directly related to the site of surgical wound. Next, the human body harbors approximately 10 to the power of 14 organisms in the body. So these can contaminate into tissues during the surgery. So here you can see the dermis epidermis is the superficial. Then if they are going into the deeper muscles and fascia, it is deep. If the organ spaces, that is the bowels, the subdiaphragmatic spaces, the paracolic gutters, and then the pelvic space. So these are called organ space infections. So let us just cover briefly what are superficial. So this should occur, the superficial incisional surgical site infection should occur within 30 days after operation. This should involve only skin and subcutaneous tissue, and they should have purulent drainage. Organism must be isolated from the surgical site, and they should have local signs of inflammation, and then the wound needs to be deliberately opened to drain the pus. So if the simple stitch abscess may not be a surgical site infection, but and the infection is episiotomy, because already there is a contamination. Circumcision site, burn wound, this we do not consider them as a surgical site infection. In deep incisional, this should occur within 30 days and within 1 year. If it is an implant based surgery, it can occur as late as 1 year. So you should keep following the patient. Now that we are doing daycare surgeries, we are discharging the patients immediately after surgery. We are asking them to come later. We are seeing them after 7 days, 14 days. So we may miss the signs of inflammation developing at the time of discharge. But if you follow up, you can see that they are developing abscesses, deep-sited infections and all. So we should nicely follow them for our audit purpose. Otherwise, we cannot know how is our performance. So, we consider deep incisional infection when there is purulent discharge present from the deep incision, but without organ or space involvement. Uh, and then deep abscess is identified by direct examination or during the operation. Surgeon or clinician declares that a deep incisional infection is present. Organ space infection can occur within 30 days or within 1 year of an implant, and it involves anatomic structures not opened or manipulated during the operation. So if it is directly involving, it is a deep-seated infection, but if it is not involved, later the patient develops. Suppose you have done a cholecystectomy, the patient develops a subdiaphragmatic abscess later. This is considered as an organ space infections. So now there is another classification. So now we have classified the healthcare associated infections, that is surgical site infections, as superficial, deep, and organ space. Now we also classify the surgical wounds as major wounds and minor wounds. We have also classified them as clean, contaminated, contaminated, and dirty wounds. Then what are major wound infections? Major wound infections are those which have a significant quantity of pus in the wound, and this has caused delayed return of the patient to home, and then he needed some surgical intervention to drain the pus, and then the patient is showing systemic signs of infection like SARS modes. Now minor wound infections are those slight discharge of pus can be there, but this is not causing any signs of discomfort like signs of inflammation, calor, dolor, rubor. These are not much. These are not bothering the patient, and the patient is nicely discharged from the hospital at a given time, and there are no systemic inflammatory symptoms. So these are the we should know to classify these infections into major or minor wounds. Then how do we classify them? What are the appearances that we consider? We know that these are the superficial, deep, and organ space, but how do we know them? So the Southampton wound grading system and asepsis grading system are the two that are devised to note and score the appearance of the wound. And then when there is scoring, we know what to be undertaken, how to be treated. So here they have divided in Southampton wound grading system. They have divided as 0, 1, 2, 3, and 4. So 0 means normal healing. There's nothing much disturbance. Up to mild erythema may be there. Still, it is considered as normal healing. When erythema plus other signs of inflammation are there, this is called grade 2. And these signs of inflammation are pain, redness, swelling at one point, around sutures, along the whole length of the wound, around the wound, that is outside the wound also. They have classified as AB2, ABCD. Next, class 3 or grade 3 infection is when there is a frank discharge from the wound. This can be clear serous or a hemoserous, blood stained. Again, ABCD they have given. And then major complication on major wound infection, major grade is given, grade 4, when there is frank pus at one point or along the wound, or there is deep-seated infection, or the breakdown in the wound, the essence of the wound is there, and there is a collection of hematoma. So you remember the Southampton wound grading system is to grade the wound into major or minor. The asepsis wound score, the asepsis is an acronym. A means standing for additional treatment, S for serious discharge, E is presence of erythema, P is purulent exudate, S is separation of deep tissues, that is adjacent wound has broken down or cut open and then spontaneously. Next, I is isolation of bacteria from wound, and then S is the inpatient stay has been prolonged. If any of these are there, within the first 7 days, they have given some points 0, 10, 5 and all. So they will add up and see what is the wound score to a particular wound. So this is for surgical auditing to know how many wounds are infected, what are the type of surgeries that are producing these bigger scores and all, so that we have to pinpoint what is the organism in the wards that is producing the particular type, because we have to devise an antibiotic and give the particular antibiotic, and we also have to prevent all if there is any uh, aseptic technique break. So several wounds causing this. For surgical audit and for surgical wound classification, this grading system of Southampton and asepsis wound score have been used. So now what is happening to the wounds, surgical wounds? So there can be a cellulitis, there can be lymphangitis, then the bacteremia, that is the bacteria can enter the circulation. Then the bacteria enter the circulation and multiply and release endotoxins. This is called septicemia. Then they produce systemic inflammatory response syndrome, multiple organ dysfunction syndrome, multiple systemic organ failure, and ultimately death. So, students, a surgical wound is not a small thing. It can lead to death of a patient. So this is a serious matter and you should learn everything and prevent and treat it as early as possible, because if you don't, it is going to enter the circulation. All the inflammatory mediators that are released locally, they're going to enter circulation and produce such modes, MSOF, and death of the patient. So now, locally, what is happening? So after cellulitis, an abscess can form, a necrotizing fasciitis can occur, a gas gangrene can occur. Let us see what are all this. Cellulitis means non-suppurative invasive inflammation of tissues. So here non-suppurative means no exact pus formation. Only there is toxic fluid under the influence of inflammatory mediators released by the inflammatory cells as a response to presence of bacteria in the tissues. Normally, there is a pinpoint or a prick point through which the bacteria enter the wound. Already, the patient may be having comorbid conditions like a diabetes, hyperglycemia, decreased immune status, or a very virulent organism. Then this produces lot of inflammatory response at the site and produces release of the inflammatory fluid. But as such, there is no suppuration, that is pus. What is pus? Death of tissue, dead necrotic tissue, dead bacteria, dead WBC are pus. So nothing, the tissue as such has not died. It is only swollen with the release of inflammatory mediators. So there will be no pus, but all signs of inflammation. See here in this picture, you can see that there is swelling and there is redness. Patient is having lot of pain and the patient is also having fever. So with cellulitis, systemic inflammatory symptoms and signs are present. So normally the cellulitis is due to beta hemolytic streptococci, staphylococci, and Clostridium perfringens. So if you don't, these produce, they release proteases if you don't treat them, and this produces tissue destruction, abscess formation, gangrene, and ulceration. So now what now? Now what is an abscess? Abscess is a cavity containing pus. I already told you pus means dead necrotic tissue, dead bacteria, and dead WBC. This is lined by a pyogenic membrane. This is a lot of tension, a lot of pressure is there because of and they draw fluid from the adjacent tissues. So the abscess will keep on expanding and this will increase the compartmental pressure and this will produce the death of the adjacent tissues. Now this abscess can be an acute pyogenic abscess because of bacterial infection, the streptococcus, staphylococcus, etc. It can be due to chronic because of a prolonged antibiotic treatment or some granuloma formation like tuberculosis and all, actinomycosis, where there's chronic inflammation established with lot of inflammation and fibrosis, ultimately fistulous tracts occurring. So these abscess, this acute abscess again has all signs of inflammation and This pus that is accumulating in the abscess cavity will keep on dissecting along the paths, along the compartments, along the intermuscular septa, and finds a path of least resistance and comes superficially and breaks into surface or into an adjacent viscous. So this abscess has to be drained by incision, and so that this will not go and track elsewhere. So these abscesses can form in a surgical wound, but as I told you, the first evidence of surgical wound infection is cellulitis, non-suppurative. But then for a frank pus to form, it will take 7 to 10 days after surgery. So as many as 75% of surgical site infections present after the patient has left the hospital and may thus be overlooked by the surgical team. So when the patient comes with a revisit, you should thoroughly examine the wound and thoroughly examine his systemic condition to rule out any local and SIRS. Now, let us see what is SSI. These definitions. Systemic inflammatory response is inflammatory response syndrome is body's systemic response to an infected wound. This is called SIRS, systemic inflammatory response syndrome. So, and then modes, that is multi-organ dysfunction syndrome, is the effect that the infection produces systemically. So these inflammatory mediators have now gone into circulation, and they're producing various changes in the various systems, producing some changes in the respiratory, cardiovascular, gastrointestinal, and then CNS. So these are called and these changes are interfering with the function of the system. So we have a multi-organ dysfunction syndrome. If at this stage also, if this infection is not checked, they are going to lead to multiple systemic organ failure, or the end stage of uncontrolled multi-organ dysfunction syndrome, resulting in the death of the patient. So now, what is systemic inflammatory response syndrome? Systemic inflammatory response syndrome, we have already seen, it is a response of the body to a particular infection. Then this, what are the category, the specific findings? They can any two of the four. What is hyperthermia or hypothermia? Hyperthermia more than 38 degrees centigrade, or hypothermia that is less than 36 degrees, and the tachycardia that is more than 90, and tachypnea more than 20 minutes, 20 respiratory movements per minute. Then leukocytosis or leukopenia, both can be there. Normally the 4,000 to 11,000 is the number of white blood cells in the blood, but they can be more than 12,000 or less than 4,000. These indicate that there is systemic inflammatory response syndrome. So two of the hypothermia, so the temperature, pulse rate, and WBC count, these three, any two if they are present, there this is called systemic inflammatory response syndrome. So now, if this systemic inflammatory response syndrome is present with a documented wound infection, we call it as a sepsis. So this SIRS can be without a documented wound infection, like an acute pancreatitis. The same systemic inflammatory response syndrome will be generated, but there is no inflammation of the pancreas as such. Similarly, burns. There is no infection, but the body, because of that injury, it has generated a inflammatory response of hypo or hyperthermia, tachycardia, tachypnea, and leukopenia, leukocytosis. But if there is a documented infected wound, we call it as a sepsis. We call it severe sepsis or sepsis syndrome if there is one or more associated organ failures and a septic focus. So these organs can be respiratory, where acute respiratory distress syndrome occurs. That is, the inflammatory mediators, the leukotrienes, the histamine, bradykinin, all these have entered into circulation and have reached the lungs. So these produce increased vasodilatation and increased vasopermeability. So now the fluid in these blood vessels in the lungs have come out into the parenchyma of the lung. So this produces a pulmonary edema-like status. Now there's a lot of fluid. The lungs are having fluid instead of air. So the diffusion of the oxygen is now hampered. So patient will go into hypercapnia and respiratory failure. So cardiovascular compromise can occur. Next, renal acute tubular necrosis can occur. Liver failure can occur. Coagulation system failure can occur. This produces a bleeding diathesis or a disseminated intravascular coagulation can occur. Even central nervous system edema can occur, which produces altered level of consciousness. So now you have learned what is systemic inflammatory response syndrome. So body's response to insult. This insult can be in the form of a bacteria. It can be in the form of a shock, hypovolemia, or any other. The body will respond to any insult. It can be a trauma, road traffic accident, or a shock by systemic inflammatory response syndrome. Next, if it is associated, this SIRS is associated with sepsis, with a wound infection, it is called sepsis. It is called severe sepsis or a sepsis syndrome if there is an MSOF. So now let us see what are the other complete. We have seen an abscess. We have now let us see what is a gas gangrene and necrotizing fasciitis. So with this we can conclude and then go to the bits. So you all know what is gas gangrene. This is caused by Clostridium perfringens, and then these are gas forming organisms, and they have a typical sweet smell in the wound, and locally there is cellulitis with lot of gas, crepitus will be there, signs of inflammation will be there, and there is blackish discoloration because of the colony of the Clostridium. Blisters will form, gas will form. This is more common in immunocompromised patients, and then military wounds where the high velocity missiles going into the tissues. This produces sucking effect in the wound, which sucks the adjacent the sand, dust, clothing, everything into the wound. So a lot of contamination is there in the wound. So you should think of this gas gangrene, and you should give appropriate antibiotic prophylaxis when you're dealing with such type of wounds. So if you don't treat, these will lead to such modes than MSOF and death. So now we have a similarly we have a tetanus infection also. So now we have an entity called necrotizing fasciitis or synergistic spreading gangrene or subdermal gangrene. This is also, so what is this great? See, you have done a neat surgery, but the patient has turned up like this. The wound has, your surgical wound has developed the depth of the skin subcutaneous tissue, and it is spreading. It may go up from the abdomen into the thorax. This is because of infection of mixed pattern of organisms in the surgical wound. They have coliforms, staphylococci, bacteroids, anaerobic streptococci, and peptostreptococci. So all of these have been infecting, contaminating the wound. So this is called a Melanese ulcer. This is called synergistic postoperative gangrene. This is called Melanese ulcer. Similarly, Fournier's gangrene if the scrotal infection occurs. In immunocompromised individuals, in diabetic individuals, there can be first scrotal edema, then inflammation, then necrotizing fasciitis leading to this skin and subcutaneous tissue gangrene, which we call as Fournier's gangrene. So in this Melanese ulcer, postoperative synergistic gangrene, or any Fournier's gangrene, there is a mixed pattern of organism, and the host response is poor to these group of organisms, resulting in a synergistic infection. If locally, if you don't control, the systemic inflammatory response syndrome occurs, leading to modes and MSOF and death of the patient. So beware any wound infection. We have to be very, very alert and control it immediately. Otherwise, it will go. If you think it is only a surgical superficial, it may go to deep organ space. Then such modes MSOF can occur and death of the patient can occur. So then how do you manage a surgical wound infection? So you have done surgery, you have discharged the patient, you ask them to come. You know that up to 30 days there can be a superficial infection, and as much as 1 year there can be an appearance of infection in the wound if you have used a prosthetic material like a mesh or an implant. So follow up the patient regularly and inspect thoroughly. When you are inspecting, look for any seroma, hematoma, and abscess. If you find anything, immediately open the sutures and drain the pus. Send the pus for culture and sensitivity. So before the report comes, do not wait for the report and immediately start a broad spectrum antibiotic. And choose the antibiotic basing on the contamination. Suppose you have done an clean surgery, that is a gram-positive organism infection can be. The surface surgeries, the staphylococcus, the streptococcus epidermidis is the cause of infection. So better start a gram-positive. If you have done a gynec surgery, there can be gram-positive, gram-negative, and bacteroids. If you have done a genitourinary surgery, gram-negative organisms. So think of the organisms or commensals present in the system. If it is the biliary tract, again it is a gram-negative. So you have to think and start the antibiotic, better a broad spectrum antibiotic, then wait for the result to come. And then you find out what is the organism, what is it sensitive, and then you switch on to narrow spectrum antibiotic. Then you inspect the wound and repeated debridements have to be done. Lay open the wound. Then you have to, otherwise if you don't follow these, there will be extensive death of skin and subcutaneous tissue leading to post-operative synergistic gangrene. If the wound is nicely granulating with your dressings, and if the wound infection has decreased and the culture sensitivity report came as sterile, then you can wait and watch. After 2 weeks, you can do a delayed primary closure of the surgical wound. Sometimes there can be a deep organ space infections when you have to do a laparotomy and drain the pus. Otherwise, the patient will end up with modes and MSOF. So now let us do on the bits with the, I think students, I have discussed now today what are the surgical wounds, how do we classify, what are the causes, what are the clinical appearances, how to grade them, how to treat them, what are the types. We have told you cellulitis, abscess, necrotising fasciitis, gas gangrene I have discussed. Now let us do some bits, right? So now here patient factors that have been shown to increase the risk for post-operative infections include all of the following except. See here you have to see and think and tell. These can be multiple or one. So here see students, diabetes mellitus, is it a cause of wound infection? Students?
Yes, ma'am.
And smoking, can it cause wound infection?
No, ma'am.
Oh.
But it causes ischemia.
Very good. So ischemia can be a cause of wound infection. Indirectly, it can produce. And then another thing is, these people who smoke have collagen abnormalities. You know, in the phase of remodeling, there is a lot of collagen that is undergoing change. From 3 to 1, the collagen will change, isn't it, in remodeling phase? So these do not occur. The good collagen will not be laid down in smokers. There is always weak scar, hernia formation, and delayed wound healing. So this also can be increasing the risk factor, post-operative infection. And then prolonged hospitalization before surgery, obesity, and then carrier, staphylococcal aureus carrier status. I feel all are causing, but obesity, can obesity produce wound infection? Students? Students? Are you there or disappeared?
Yes, ma'am. Can obesity also?
Obesity, lot of the blood supply in the fat is less. So if any bacteria enters, it will easily colonize and it will produce this postoperative synergistic gangrene and all. And Staphylococcus aureus carrier status, again, this can be a cause. So only I feel prolonged hospitalization before surgery relatively less, but still it is a cause of infection because hospital acquired infection during the procedures can occur. So here I don't know what to put, but this bit is given in a book and they have given the answer as C. Next, this Koch postulates. Which of the following are part of Koch postulates? I have discussed, I have told you three. Just find out. It must be found in considerable numbers in septic focus. Yes or no?
Yes, ma'am.
And
It should be isolated.
Reduction in the organism should be achieved by using appropriate antibiotic. That is not given. It should be possible to culture it in a pure form from the septic focus. Is it given or not?
Given, ma'am. True.
Healing of a wound is possible without pus formation. This is not there.
Not
it
given.
should be able to produce similar lesions when injected into another host. It
Yes,
is there
ma'am.
or not?
It's there, ma'am.
So 3, A and then C, E. I think these 3 are mentioned. So these are the answers. Do you agree? This one's Koch postulates. Next,
Yes,
which of the following is a natural barrier to infection? See, we have found that they are mechanical, chemical, humoral, and cellular. So here, natural, these are normally present. Just find out. Intact epithelial surface. Is it there
yes,
or not?
Yes, it's there.
High gastric pH, high or
No.
low?
Low gastric pH.
Low gastric pH. This is doubtful. Antibodies, yes or no?
No, ma'am. They will produce once the infection comes. Since it is
naturally
natural.
we may have some antibodies now. For that only we are taking all vaccines, isn't it? To prevent infections. Naturally,
it is induced, no, ma'am. How it will become natural? It is induced by the vaccine, no, ma'am. Vaccine is another form of organism.
But we are generating that and we are making it ready. Antibiotics, are they natural? They are not.
No, ma'am. No.
Macrophages?
Yes, they are.
Macrophages are there. So here I feel intact epithelial surface. This high gastric pH is doubtful. Antibodies, we are inducing natural barriers for infection. Naturally, the body is naturally producing. We need not give anything also. Suppose community acquired infections. Suppose the people staying in the developing countries, they develop some immunity against some infections. But people who are coming from Western countries, suddenly they will have lot of infections, isn't it? So naturally, we are developing immunity by naturally producing antibodies. Do you agree or not? We need not take vaccines also sometimes. Naturally, then we get exposed. So we'll see what it is now. Host resistance to infection. Which of the following is a cause of reduced host resistance? Malnutrition?
Yes, ma'am, it's a cause.
Heart failure?
Yes, ma'am, it is a cause.
Think. Cancer?
Cancer, yes, ma'am.
AIDS? Infection?
Yes. Yes, ma'am.
So heart failure, the patient.
But reduced blood supply will be there.
But still, heart failure as such,
relatively,
it is a status where it's only a temporary status. What he will acquire. So malnutrition is a prolonged status. Cancer is a prolonged condition. Acquired immunodeficiency is a prolonged condition. Heart failure is a temporary and an emergency condition. I feel B is not. A, C, D. Let us see what they have given. Okay, right. ACD is given, and there also ACE is given. We have taught antibiotics. Are you satisfied with the answers, students?
Yes, ma'am.
Secondary infections. Which of the following is a cause of secondary or exogenous infection? That means it is not primarily acquired from the community. B is not. B is a primary. We know that. Then poor hand washing technique. Poor hand washing technique means it is secondarily coming from the, so poor hand washing technique. B, it is not. Perforated diverticular disease. Perforated means primarily it is endogenously the bacteria, they are coming out. So it should not be C. But anastomotically, secondary to a procedure, it is occurring.
It is secondary.
So A, D. Then inadequate air filtration in the theater. This is also breaking aseptic. So the answer should be A, D,
C, E, ma'am. A, D, E, ma'am.
Let us see. Wow, very nice. Now, which one? This one we'll see. Which of the following statements about surgical site infections are true? See, I have told you several: superficial, deep, and organ space. I have also told you major and minor wounds. This is what the bit is dealing. So, which are true? These are multiple answers. Be careful and see. Infection in the musculofacial tissues is known as deep surgical site. Yes or no?
Yes, ma'am.
Yes. Patient may have systemic signs in a minor surgical site infection. Yes or no?
No.
No. Infection causing delay in hospital discharge is a major surgical site infection. Yes or no?
Yes.
Yes. Differentiation between major and minor SSI is not important. Yes or no?
No, ma'am, it's important.
No, it is very important because it will cause death of patient. Surveillance for surgical site infection should be done for a year after implanted surgery. Yes or no?
Yes, ma'am, true.
So your answer should be A, C, and E. Let us see.
Yes.
Wow. So A, C, E. Very good. Now coming to abscesses. Which of the following statements regarding abscesses are true? Staphylococcus aureus is one of the most common causative organism. Yes or no?
Yes, true, ma'am.
Yes. Abscess wall is composed of epithelium. Yes or no?
Yes, granulation will be.
It has pyogenic membrane or granulation. It does not have an epithelium, right? If it is lined with the epithelium, a cavity lined with epithelium is called cyst.
Cyst, yes.
So this is not. So B is wrong. Most wound site abscesses occur before the patient is discharged from the hospital. Yes or no?
No, ma'am, because 7 to 10 days it will take.
It will take 7 to 10 days and 70% will occur after discharge only.
Yes.
Right? So this is no. Antibiotics are indicated if there is evidence of cellulitis. Yes or no?
True.
Yes, because if you don't put, it will lead to abscess, necrotizing fasciitis, and modes and death. So D, actinomycosis can cause a chronic abscess. Yes or no? Yes, they produce the tuberculosis, actinomycosis, all these produce chronic conditions, chronic infections. Okay. So are you satisfied, student?
Yes, ma'am. Yes, ma'am. Yes.
Okay. Next. Cellulitis, a bit on cellulitis. Which of the following statements regarding cellulitis are true? This is a non-suppurative invasion of tissues. Yes or no?
Yes, true, ma'am.
True. It is poorly localized.
No, ma'am, it's well localized.
Oh.
No, it's it can be seen, no, ma'am, signs of inflammation.
But it will spread, no? It will spread throughout the limb. The prick can be one place, but the whole limb can get swollen. So this must be true. Next, commonly caused by Clostridium perfringens.
No, ma'am, beta hemolytic strep.
See, this is we don't get gas gangrene for everything. Systemic signs are not present.
They are
Systemic
present.
signs,
No?
they are present. So this is wrong. Blood culture is usually positive.
Yes, ma'am. Systemic, then
No,
blood culture.
blood culture is not positive for cellulitis, right? You won't get, because only systemic inflammatory symptoms will be there, but that as such will not produce a bacteremia or a unless there is septicemia, the blood culture will not be positive. Understood? The bacteria should grow, go into circulation and multiply, then only you can get a blood culture. So I think even blood culture is positive, is absent. So what should be A, B? What is the answer? A. Which of the following are true? A, B, D. D, systemic sign. So these are actually A, B, D. Systemic signs are not present is wrong. Blood culture is usually positive. Which of the following statements regarding cellulitis are true? I feel only here this bit can be A, B, D and E doubtful. No, they are not there. So D, you verify in the book, they are not there. A, B should be the answer. Next, systemic inflammatory response syndrome. So what is SIRS? I told you. What are the three factors that you have told? One is temperature. The other one is pulse rate. Third one is respiratory rate.
Respiratory rate.
So here you see hypothermia. Is it there?
Yes, ma'am.
White cell count less than 4. Is it there?
No.
Yes, 4 to 11. It can be above 11 or it can be below 4. That can be due to infection, suppression of bone marrow, and the leukopenia can occur. I was telling you, no, there can be hypothermia, hyperthermia. Similarly, leukocytosis, leukopenia. So both can be there. It is below normal. Normal is 4 to 11. 4, understood? 4,000 to 11,000. It can be below 4,000 also. If the patient is having leukopenia, that means he is in SIRS. Understood? And can it occur without a documented infection? Can it occur without a wound infection? SIRS? I told you, no, two facts. Pancreatitis, burns. These are the conditions where there cannot be. See, when the patient gets a burn wound and comes, immediately there may not be any infection. But immediately there will be SIRS.
SIRS with the
SIRS without can be with a documented wound infection or without a documented. So both can be there. If it is with a documented wound infection, we call it as a sepsis. Understood? You understand? Hello? Are you there? Students? So hypothermia, leukopenia is given, no documented infection can be there, tachycardia can be there, tachypnea can be there. So I feel all are seen in SIRS. What do you say, students? Students? So the answer again, all are there in a SIRS. Next. Which of the following statements about severe sepsis are true? So severe sepsis or sepsis syndrome means actually according to definition, there is a septic wound and there are SIRS and there are also going to modes, that is multi-organ dysfunction syndrome. So let us see what are the answers that are given. Acute respiratory distress syndrome is common. There is students, are you there?
Yes, ma'am.
So ARDS can occur, isn't it? We have seen that respiratory, renal, hepatic dysfunction, cardiovascular, CNS, all dysfunctions can occur. So ARDS is common. Next is there is absence of documented infection. Do you agree? In severe sepsis and sepsis syndrome? No. So this is wrong.
No.
A is correct. Next, multi-organ dysfunction syndrome is a systemic effect of infection. Yes or no?
Yes, ma'am.
MSOF is the end stage of uncontrolled modes. Yes or
Yes,
no?
true, ma'am.
Yes. MSOF is mediated by released cytokines such as interleukins and TNF, tumor necrosis factor. Yes or no?
True, ma'am.
True. So here I feel the answer only B should be wrong, while the other should be true. Okay, correct. Next, which of the following statements are true? Identification of the causative organism should be done before starting antibiotic. Yes or no? Students?
Ma'am, voice is not clear.
Identification of causative organism should be done before starting antibiotic. Is it necessary?
No, ma'am.
No, I have already told we have to start broad spectrum antibiotic, empirically start basing on the probable organism that is there. So not necessary, otherwise we will land up with certain modes. So A is wrong. Wounds are best managed by delayed primary or secondary closure. Yes or no? Suppose you find surgical wounds are infected. Do you think delayed primary or a secondary closure is better or primary closure is better? Students, are you able to hear me? Students?
Yes, ma'am. We can hear.
So if you suspect a wound infection, better not close the wound. Keep it open. Check after 2-3 days. If there is no signs of inflammation, no signs of dead or necrotic tissue, you can close it. This is called delayed primary closure or a tertiary intention. Secondary closure means what? Wound healing with granulation tissue. So I think B is correct. B is true. What do you say? Are you able to hear me?
Yes, ma'am. True. Yes, ma'am.
So now, subcuticular continuous skin closure decreases the incidence of wound infection. Do you think it is correct? If you tightly close it continuously, if suppose something happens and if there is a fluid collection or a blood, it cannot come out, then it will produce wound infection. So this must be wrong, isn't it?
Yes, it's
Interrupted
wrong.
sutures, you can open a suture or in between gap fluid can come out. So this is also wrong. Polymeric films can be useful in infected wounds. Do you want to put foreign material in the wound? Will it increase the infection or it will decrease?
Increase.
So this is also wrong. Administration of antibiotic preparation locally is more effective than oral route, which is true.
Not true, ma'am. It's not true. Orally is good, ma'am.
Orally is good because it will go into systemic circulation, it will prevent any bacteremia, and it will neutralize the harmful endotoxins that are produced. And locally some people may have allergy, and because of the high concentration there can be death of tissue also. So this is also wrong. So what are we left with now? B only, isn't it? Let us see. Yes, very good. Now, which of the following affects the choice of prophylactic antibiotic? Prophylactic antibiotic is the antibiotic that you give during the decisive period. You understood? Prophylactically before you do a surgery. So how do you plan which antibiotic to be given? I have told you. You should think what are the organisms that may infect. If you're doing a surface surgery, gram positive. If you're doing a GI surgery, broad spectrum, all three can be there. If it is a biliary tract, gram negative. Genitourinary, gram negative. So is it true or not? A?
Yes, ma'am. It is true.
Cost also, suppose you have two or three, and which one means definitely some cost also we have to think. Personal preference, that means personal preference, hospital policies, local resistance strain. I don't know, I'm thinking all. Personal preference means your experience.
Yes, ma'am.
Hospital
Yes,
policies,
ma'am.
hospital guidelines will be there. So yes, that also. And then local resistance strain. So all are B. C, ABC is not. Personal preference. So, okay. The personal preference here means evidence-based, not personal preference. So, you cannot give what you want. Correct only. You have to think. Suppose you want to give for a surface surgery only gram positive. Why do you want to give a broad spectrum? Understood? What do you mean? So evidence based only, you can't just your whims and fancies, you can't. So that may be the answer. Which of the following may require more than one dose of prophylactic antibiotic? Prolonged operation? Yes or no?
Yes, ma'am. Yes.
Excessive blood loss? Excessive blood loss, what should you give? If there is excessive blood loss, you want to give antibiotic or you want to give blood?
Transfusion.
So I don't think this one. Gastrointestinal surgery. Gastrointestinal surgery, you can't just give one dose and stop. You may have to give, a second dose, or you may have to give therapeutic dose basing on if there is contamination. So gastrointestinal surgery, definitely one dose may not be sufficient. Insertion of prosthesis. Do you want to give more than one dose?
Yes, ma'am.
Yes. Unexpected contamination. Suddenly there's spillage. Spillage from gut. You have to give. So I feel A, C, D, E must be. Let us see. A, B, D, E. A, B, D. That's wrong. Gastrointestinal surgery you have to give. I feel these are the answers. Which of the following statements about types of wounds are true? See, we have divided into clean, contaminated, and dirty. They are asking, you have to find out what is a true out of this. Infection rate in a clean wound is between 1 and 2%. Yes or no?
Yes, ma'am. True.
Wound after a biliary surgery is classified as contaminated. Yes or no?
Yes. No,
biliary surgery is clean contaminated. So this must be wrong. A clean contaminated wound has an infection rate of less than 10%. Yes or no?
Yes, ma'am.
Yes. So clean wound 1 to 2, clean contaminated 10, contaminated 20 to 30, and more than 40 dirty. That is the rate of infection. You have to expect and you give antibiotic beforehand. Antibiotic prophylaxis would be mandatory in dirty wounds.
Yes, ma'am.
Dirty wounds prophylaxis. Already they are dirty. They have come dirty. So we have no
debridement.
You have to do other things. We have no chance or to give prophylaxis. Understood? So here they've come already dirty. We have no chance to give prophylaxis. These doubtful. Role of prophylactic antibiotics in non-prosthetic clean surgery is controversial. Yes or no? See, antibiotics should be used as much less as possible if you anticipate no infection, because if you bombard or use high doses of multiple antibiotics, it will produce drug-resistant strain and bacteria. So we want to use them as much less as possible. So when you're doing a clean surgery and non-prosthetic, some say single dose you have to give, some say no need to give. In Western countries, they don't give, and in our developing countries, we give, because our break-in asepsis is much more than them because of population. The amount of people movement in the theater itself is enough to produce any infection and break-in asepsis. So this is controversial. I think this is also is correct. So what we are left is this dirty wound and prophylaxis are not matching, because we have no chance to prevent. Suppose sudden road traffic accident. So here they have given
one question, ma'am. Suppose a dirty wound comes to your ward, ma'am, whether we should do first procedure or give antibiotics then procedure?
That is not a prophylactic, that is therapeutic. The antibiotic that you are giving is for treatment. Yes. Understood? Prophylaxis is before establishment of any infection. I told you decisive period, no?
Yes, ma'am.
That is called prophylactic. But here, there is no decisive period like that for dirty wound. Yes or no?
Yes, ma'am. Yes.
So now
Yes,
you
ma'am.
understood?
Yes, ma'am.
Now you have to match here. This one. Prophylactic antibiotics. Second generation cephalosporins and metronidazole. Where do you give? Think of the bacteria that are present. Biliary, colorectal, orthopedic, vascular.
Colorectal, ma'am.
Metronidazole means better we think of colorectal. We'll keep
Colorectal.
D. 1D we'll keep. Next, broad spectrum cephalosporins with anti-staphylococcal action or gentamicin beads. I told you
Orthopedic, ma'am.
orthopedic. Okay, we'll see. Flucloxacillin with or without gentamicin, vancomycin, rifampicin. If MRSA is risk, we are very, very cautious that we may lose. So where do you give? Vascular, isn't it? Yes or no?
Yes, ma'am.
Next, second generation cephalosporins is biliary, right? Let us see. 1D. Second generation cephalosporin colorectal is correct. Broad spectrum orthopedics is correct. Flucloxacillin vascular is correct. So all are correct. Do you agree? Are you satisfied?
Yes, ma'am.
Next. Here you see, you have to match the type of bacteria with the property that they have given. Lactose fermenting gram-negative bacillus, which is the most common cause of urinary tract infection. Strepto, Staphylo, Clostridium, E. coli, Proteus, Pseudomonas, bacteroides.
E. coli, no?
So, one we'll write as D. Gram-negative bacillus, which tends to colonize burns and tracheostomy wounds. These can also cause UTI, and they also acquire drug resistance. See,
Pseudomonas.
burns,
Pseudomonas.
oh, very good. So Pseudomonas is the answer. Non-sporing, spore-bearing anaerobes that colonize the colon, vagina, and oropharynx.
Streptococcus.
Oh, anaerobes. Non-spore-bearing anaerobes. So bacteroids.
Clostridium.
Non-spore-bearing. They're spore-bearing, no? Clostridium is a spore-bearing, no?
Yes, ma'am. Yes, ma'am.
So this must be bacteroids. Let us see. 3G will keep. Gram-positive cocci, which forms chains, causes cellulitis and spreading tissue destruction by release of enzymes.
Streptococcus. Streptococcus. Streptococcus.
Streptococcus. Non-lactose fermenting gram-negative bacillus, which is a normal resident of the colon and is a cause of intra-abdominal infection after bowel surgery.
E. coli. E. coli or Proteus?
E. coli or Proteus. Both of them look. So one is lactose fermenting, another one is non-lactose fermenting.
But
Next.
E. coli is common commensal, no, ma'am.
Common and is a cause. So this must be that. We'll see.
E. coli.
Gram-positive obligate anaerobes which produce spores cause serious gangrene, tetanus. So obvious is Clostridium.
Clostridium.
Gram-positive aerobic coccus which forms grape-like clumps causes wound and prosthesis. Methicillin-resistant Staphylococcus aureus. So this must be
Staphylococcus. Staphylococcus
so, so we have to see what is lactose fermenting, what is non-lactose fermenting. UTI, E. coli or Proteus. So D, the 1 and 5 are little. So 5 is E they have given. So lactose fermenting. 1 is D. So E. coli is lactose fermenting. Remember like that. Even I don't know. So this is a lactose fermenting gram-negative bacillus, which is common cause of UTI. So non-lactose fermenting means Proteus. Otherwise, all have matched. Okay.
Ma'am, ma'am, once again, previous question. Is Proteus is a normal commensal, ma'am? Normal resident?
They are. Proteus is present even in UTI or urinary tract also. E. coli Proteus.
Yes, ma'am.
And the E. coli Proteus are gas forming. They form gas. You know, they produce non-clostridial gas gangrene. Right? But you have to go to your microbiology book and study thoroughly, right? Different types. Now you see, you have to classify these wounds into these 4 types. Drainage of an abscess. What type of surgery it is?
Dirty.
Dirty. No viscous opened.
Clean.
Gastric and biliary surgery.
Clean contaminated.
Very good. Wound infection rate 1 to 2%.
Clean, ma'am.
Very good. Open viscous surgery with gross spillage or inflammatory bowel disease.
Contaminated.
Very good. Wound infection rate 15 to 20%.
Contaminated.
Wound infection rate more than 10%. Sorry, more than 40%.
More dirty.
Dirty. Wound infection rate 10%.
Clean contaminated.
Very good.
But ma'am, seventh question, it is more than 40, no ma'am. Here it is given
more than 40 is dirty.
But here it is
more
given
is dirty.
Here it is given less than 40%. So clean, contaminated, and contaminated wound comes in those.
Wound infection rate 50 to 20, 40, 10. In less than 10 is, see, you actually 10 or less than 10. You take the number 10. So actually it is more. It can be anything. Let us see what it is. 7D. So it is not dirty. As you said,
yes,
contaminated. 7 dirty. So they have given dirty. So if the number is 40,
yes,
you keep it as dirty. There will be some very subtle wrong in framing of questions, you know. That is very sometimes.
Question is correct only, ma'am. That symbol says it is less than 40, ma'am. While you are telling the question, you told it's more than 40.
More than 40. So
question is correct.
40 or more.
Yes.
It can be any, right? It can be 40 or from that anything it can be, right? That is what we have to know. So with this, we have concluded. I think you had some idea of wound infections. What are the various types of surgical wounds? Major, minor, and then we have wound scoring systems, aseptic scoring, and Southampton's wound scoring system. We have also divided surgical wounds into clean, contaminated, and dirty. We have also types of infections like cellulitis, abscess, necrotizing fasciitis, gas gangrene. We have discussed. We have also discussed the management of surgical wounds. Hope you have had some idea. Go back and study. You will have more idea. Thank you, students. What shall we have for the next class? What shall we have? Wound infection. We have trauma, traumatic wounds. Boring. We won't have anymore. Shall we take a burns? Students?
Swellings we can take. Swellings, ma'am.
Swellings.
Yes, ma'am.
Swellings. It is a clinical class, no? Swellings. It is. Yes. We cannot. You are basically. You want MCQs, no? We have to discuss bits. Or how do you want? I can discuss, but.
Yes. But rest are general surgeries, ma'am. Venous diseases, arterial diseases.
And then you are which semester students?
Final year.
Final year. So can we take up other final year chapters like salivary gland tumors or other breast? What other classes are taking? They are taking.
Jyoti madam taken this spleen, and yesterday madam spleen madam has taken already.
So shall we go as systems? Arterial system, venous system?
Yes, ma'am.
So I will try to cover arterial system.
Yes, ma'am. That's big chapter. Yes.
Big chapter. First we'll have only theory. Later we'll have bits.
Yes, ma'am.
First we'll have because unless we cover theory, I don't
Yes.
think we can discuss the bits, right? So
Yes,
I will start arterial system. Thank you so much.
Thank you so much, madam. Thank you, students.